Dr. Dona Benadof, whom we'll welcome back to the stage, is a clinical laboratory specialist, and she is the head of the Clinical Laboratory and Core Antimicrobial Stewardship Program at Roberto del Rio Children's Hospital. She is also a member of the Antimicrobial Stewardship Program Committee on the Chilean Society of Infectious Diseases and a member of the Board of Directors of the Chilean Society of Clinical Laboratory Medicine. She also holds the post of adjunct professor in the Department of Pediatrics and Surgery at the University of Chile. She is here to share her expertise of evidence-based stewardship strategies in the surgical setting. Let's welcome her back to the stage.
Thank you for the presentation. I'm a little short, so I'm going to put this down. Well, let me see. Oh, there. These are my disclosures. I'm going to read this because this is AMS mantra, and I think it's very interesting. If you love AMS, you have to have it in your head. You have to focus on best practice. AMS involves systematic assessment and collaborative initiative to optimize the use of antimicrobial agents in terms of their indication, evaluation, and duration and administration. And this mantra is very important in surgery. When you go to surgery wards, you have to talk to surgeons with metrics. So the first thing you have to do is make an evaluation and give them something objective with what they have to work. So in our country, we participated in a PPS, a point prevalence survey. We are part of what we call the Latin American PPS group. And as you see here, there's Chile, Colombia, Mexico, Peru, Panama, all from Latin America. You can see that there's a big problem in surgical wards. Between 50 and 60% of the antimicrobial use that we find in this PPS of a lot of beds surveyed, we have the use of antimicrobials in surgery wards. So it's the first thing to say, it is a problem. And when we look at worldwide, including other continents, we can see that also is an issue. So in this publication, you can find that in low-income and middle-income countries, the second problem is prophylactic, surgical prophylaxis. And when you look at what are the problems that are the issues that we have to take in AMS, is take care of prophylaxis. So when we talk about prophylaxis, we talk first of adherence. To have adherence, you have to have guidelines. If you have guidelines, you have to work with surgeons, you have to work with anesthesists, you have to have your epidemiology, you have to work with infection control. You have to choose wisely, I like that two words, choose wisely the antimicrobial for prophylaxis. And it's important, the choosing, because the choosing goes with the timing, the dose, and the duration. If we talk about cefazolin, it's one dose, one time. If we talk about vancomycin, it's 1 hour before the incision, and it's out probably of the operating room, the administration. So this concept has to be in prophylaxis. You have to have all these points together when you look at prophylaxis and doing AMS in prophylaxis. So if we look about evidence in prophylaxis and AMS, we can have a look at this publication that is a systematic review. And it shows 14 studies before and after. And what they show that AMS can be effective in almost 90% in the increasing adherence to surgical antimicrobial prophylaxis. And also, if you have adherence, you can have better results diminishing surgical site infection. Also, in this review, you can find data of cost effectiveness that is important for stakeholders. And also, what strategies they show that were the better strategies, such audit and feedback, education, implementation of protocols, and of course, clinical decision support system. There are other strategies to have data. One is PPS. We talked in the morning that it's very, you have to have a lot of work because you have to revisit all the data of every patient hospitalized in one day or in one ward. So it's hard work. But you have very, very good data that I'm going to show you that we found in our institution. You can do daily surveillance. Daily surveillance is easier for metrics. What you do, you decide to, for example, looking at the first 10 patients in one ward, and you audit every day those first 10 patients, or weekly. That is easier, but you can have a metric. And also, you can look at the correct use of antimicrobials and work with trying to change the culture. But to do that, you have to do education, and that is not so easy. Outside of prophylaxis, there are also objectives in AMS surgical wards. And what are these? First, empirical therapy, but you have to have local evidence, so you have to work with the lab, okay? You have to have the epidemiology of your Escherichia coli, your Klebsiella, you have to have your data, so you can work in your guidelines. De-escalation based on cultures. But to do this, surgeons have to take cultures. And that is very important because they sometimes think that the lab is something unreal, something, this black box, that something happens inside, it comes a tube, a swab, and it gets out a paper with something that sometimes they don't know how to interpret. Switch EV to oral. You go to surgical wards, the patient is eating, is taking some medications orally, but is with an IV infusion. So you have to open the eyes of surgical wards, work with nurses, are very good allies in this strategy. Discontinuation of empirical treatment where there's no proof of infection. That is something that you can work with the ID team because sometimes they are scared of getting out of the antimicrobial because they feel secure with the antimicrobial. So AMS team is very good in that strategy, in that objective. And also being with the ASM team, working with them. The ASM team has to be with them, not above them. What do we do wrong in surgery wards? First, cooperation. Because sometimes surgeons do not like AMS. They think they're going to tell me what to do. So you have to do a very strategic work with them. Sometimes it takes coffee and chocolate, as I say. You go with them. Hey, do you want a coffee? Let's talk about AMS. Let's talk about antimicrobials. And we do that with Mirta a lot. Use the laboratory resources. As I told you before, they do not have the education in what does the laboratory do. This is a black box. So you have to teach them to use that well. And also to use well biomarkers. Somebody talked about that, and it's very important because it's one of the issues, it's one of the tests that has the possibility to rule out an infection. So it's something that AMS has to work with them. And when we talk about laboratory resources, here you can see a slide that in the down part, it's pixelated, I'm sorry. You have the workflow of the lab, okay? And on the upside, it's where the lab collaborates to use well the antimicrobials. So in the lab, we have time. If you look at the cultures, 72 hours, 48 hours, sometimes more, okay? You can say, no, we have MALDI, we have PCR, we have other strategies, but mainly we have 48 hours at least, okay? So they sometimes send the swab at 2 hours, I want the result, because they don't know what happens. So we have to teach them this. And also, we have to teach them how to use a pretty important information that we do in the lab, that is the cumulative susceptibility information or data. Because with that, we can make the guidelines, because with that and the identification in a culture, we can do a semi-targeted antimicrobial treatment, and also because with that, we can have the better result for the patient. This is our hospital. It's a 100-year-old hospital. We have 200 beds and 45 ICU beds. A cardiothoracic ICU and a pediatric ICU is the biggest ICU in my country. So we have to have, complex patients. One of the things we did to put all the clinicians in synchrony with AMS was to work in an AMS software algorithm. We have a software since 2013. Every prescription of every antimicrobial that is not accessed, that is reserved or watched, is prescribed through this AMS software. So in business hours, they have to think what they want to prescribe. They have to justify what they want to prescribe. They have to put the signs, the symptoms, the results of the cultures, everything. So after that, they put that in the software. It comes an alarm to the ID team. So the ID team knows where I prescribe in our hospital, everywhere where there's an antimicrobial prescribed. And they go and they look at the patient with the treatment, with the clinician, with the surgeon, with the traumatologist, with the oncology, etc. And they decide together what they're going to do with the patient. So we do not say no. We just say, let's look at your patient, let's look at the data, let's look at the cultures, let's look at the biomarkers, okay? So together, we decide if we do the authorization, and that goes to an alarm to the pharmacy, and the pharmacy is dispensing. In not business hour, what clinicians were preoccupied was that they lose the liberty of prescribing antimicrobials, and that would get a higher rate of mortality in their patients. So what do? In non-business hours, the pharmacy dispatches. And the next business hour in surgery, it comes the ID team and look at the patient. So it's 2 or 3 doses that are dispensed by the pharmacy. And this has been a very, very good strategy because we have almost 100 of adherence to this system. Another strategy that we've been working with surgery and also with another clinicians is real-time alerts. As I told you in the morning, we have a LIS that is customized for microbiology, and we customize the alerts. So it's back to drug. For example, Staphylococcus aureus with methicillin resistant. When you work in the lab and the software asks you, do you want to send an alarm? Yes. And that alarm goes to the mail of strategic persons that are always looking at the mail, and they do things with that information. Because it's not good to make an effort in the lab if nobody's going to see the alert. Also, we have some WhatsApp group. We have a WhatsApp group of the residents, because also this type of alerts come in 24 hours, 24/7. So if an alert, for example, is dispatched at 1 a.m., okay, sometimes the residents are looking and they go look for the patient and they change the prescription. This is an example, a real example that happened the 2 of November. Here you can see that Doctora Acuña is in the WhatsApp, and this is the resident, the nice resident. They're very nice, all of them. The alarm of the lab says that this patient, this 14-year-old patient with a fracture dislocation, operated using osteosynthesis material, went to the emergency room, and we took a culture, and the patient was hospitalized with cefazolin, okay? And the 2 of November, it comes this alarm that it says that culture is a Staphylococcus aureus methicillin resistant. So Dr. Acuña, what says to the resident, because this was a not working day? She says, hey, is someone there? This nice resident said, yeah, hi, I'm here. And she said, can you look at this patient, please, because it's not going to work, cefazolin. So you have an action in real time. Also, as I said to you, point prevalence survey, we do it every year. I show you this result because these were part of the publication that we did in the Antibiotics 2025. And what we found here was that the 3 first diagnoses were surgical diagnoses: intra-abdominal infection, tissue and skin and soft tissue infections, and prophylaxis. When we looked at prophylaxis, we have a huge amount of cefazolin, but we have other antimicrobials. So Mirta said, we have to do something. We have a weekly reunion, and we look at this data, because here it can show that 77% of these prophylaxis were done by the guidelines, but 23% were out of our guidelines. So we have a problem. What did we do? We went to talk to the head of surgery and traumatology, and he said, well, we have to do something because I've talked to them. The guidelines are available, and we have reunions every month. We go to the reunions every 3 months, and we thought together that we have to do a training course for them. And what was important in that year, we were at COVID. So all the hospital was at COVID, and surgeons were taking coffee all day long. And it was very important because they show that a very interesting interest in doing this course. And we planned in a platform, in a mobile platform, hybrid platform, a 6-week course, hybrid. And we only have one presential session, that it was to show them what we did in the lab, in this black box that is lab, okay? We talk about topics like from sample collection to culture workflow, antimicrobials, basic things, basic, not elevated, prophylaxis, treatment in surgical pathology, and they told us what themes they wanted. They wanted urology, head and neck, cardiothoracic, intra-abdominal, traumatology. So we took what they wanted. And also we have clinical cases session and demonstration of the sampling material, because they didn't have clear knowledge of what was the better things, or a swab, or a syringe, to take the better sample for surgery. So we train 100 surgeons in our hospital. That's a huge amount of surgeons. Also, some nurses wanted to do the course, and they took it, and some pharmacists of our hospital and other hospitals. And what we found was that they were pretty interested in antimicrobials, And what was like a win-win in this training course is that they decided they wanted to work actively in their guidelines. At first, there was 1 or 2 surgeons working with us in guidelines. Right now, there you can see that there are urologic surgeons, traumatologists, intra-abdominal surgeons, anesthesiologists working with us in the guidelines of, for example, this was appendicitis. And all the signatures you see there is all the people that work with us. So this is a huge change of mind. So in conclusion, here we can see all the things that are the things that affect improper use of antimicrobials. But we can see that in the positive way, we can do many things, like, for example, working in guidelines with people, making them their guidelines, not our guidelines, imposing them. They have to feel it's their work. Also, to look at the laboratory and take a deep understanding of what they have to do to make the best result. If you are in the operating room, I think maybe some of you do infection control and supervision in the operating room. When someone is operating and is going to take a culture, he does this. What does this mean? Give me something, I'm going to take a culture. Sometimes it's 400 cc. The patient is open, 400 cc. And what does the nurse give him? A swab. What do you do with a swab in the lab? Almost no, yeah. So we now are looking at that moment as a precious moment to introduce and change in them. So we are working now this year with the nurses. We're going to teach the nurses in the operating room to give the surgeon the best of what they have to take. Because that's a unique opportunity. You have the patient open. You have 400 cc of pus of an abscess. You have to take 10 cc, 20 cc. And there comes the order to the lab, and they want 20 different things. So with a swab, you cannot do nothing. So we are working now in that issue with surgeons. And also give them back their metrics. Measure what they do, but work with them with their metrics. I think that's a pretty key, important thing to do. And with surgeons, it's not like a 100-meter race. You cannot do something and expect a change in low time. It's like a 42K. You have to work with them a long time, accompany them, work with them, always not above with them, and always show them their metrics. I think that's the key for success with surgeons. Thank you.